next speaker in this theme is Dr. Erfan Ibrahim. He joins us from the United States of America, and he's the founder and CEO of the Bit Bazaar. Over to you, Erfan.
Hello, my name is Erfan Ibrahim, and I'm the founder and CEO of the Bit Bazaar LLC in California, USA. Today, I'm going to be comparing different predictive models for COVID-19. My background is that I have a BS in physics from Syracuse University, a master's in mechanical engineering from the University of Texas at Austin, and a PhD in nuclear engineering from the University of California at Berkeley. I have worked extensively in physical sciences and mathematics and engineering. I have worked also in the field of energy, networking, and cybersecurity. During these years, I have done a lot of work in mathematical modeling. And over the last 33 years since my doctorate, I have worked at Lawrence Livermore Lab, Pacific Bell, the Bit Bazaar, the Electric Power Research Institute, and the National Renewable Energy Lab. I've also spent some time as a research engineer at UCLA. I do a lot of public speaking in science and technology. I also give presentations on business process and on policy. Currently, I am running the Bit Bazaar LLC as a cybersecurity consulting company. The COVID-19 disease has spread globally, and as you can see, we have over 23 million people infected as of August 23rd, 2020, with over 800,000 deaths, and some 15 million people have recovered. The 4 nations that we see that have the highest level of infection are USA with 5.7 million, Brazil with 3.6 million, India with 3 million, and Russia with 952,000. These countries started the growth of the infection started at different times. In the US, it started pretty early in March, and in Brazil, India, and Russia, it happened subsequently in the May-June timeframe. If we look at the infection data across the globe, here are some statistics on the number of infections, and you can see how Brazil, USA, and India are disproportionately representative of the virus, COVID-19 virus. While there are several other countries that have a lot of infections, but proportionally looking at this, Brazil, USA, and India, and to some extent Russia, are leading. If we look at the fatality data in terms of number of deaths, you see some countries like Italy, France, and Spain are also showing large numbers of deaths, as well as Brazil, USA, India, and Russia. And if you look at the clinical fatality rate, which is basically the clinical death numbers divided by the clinical infections that are documented, you can see that Italy and France and Spain are leading in the clinical fatality rate. There are several reasons for the high clinical fatality rate. If the patients were over 60 years of age, had comorbidities, the percentage of patients that die from COVID-19 is pretty high. Also, certain countries have better healthcare than other countries, and you see variations in the clinical fatality rate based on the quality of healthcare. Also, the number depends on the extent of testing. So the more testing that is done, the larger the percentage of people that got COVID-19 would be documented, and then that would lower the clinical fatality rate significantly. And also, how are the deaths documented in the death certificates? There may be situations where the patient has some comorbidity and died as a result of that, and it could be documented as a COVID-19 death. Or there was a patient who died and there was no COVID-19 test done, and it was just presumed based on epidemiological data that this person may have had COVID. So all of these factors affect the accuracy of the clinical fatality rate. There are many reliability challenges with COVID-19 statistical data. The first is that there is no global standard for COVID-19 statistical data collection. Every country, and even within the country, every province or state, and even down to the individual hospitals, have their own unique ways of documenting the patients that come in and those who recover, those who die, and that data is then compiled and sent to state or provincial level and eventually to the national level. But in the absence of a global standard, there's tremendous variability in the accuracy of that data. There's also tremendous geographical variability in the extent of testing of infected people. Some countries like South Korea and Germany and Iceland and New Zealand, you see very, very extensive testing done on the suspected population. And then other countries, not so much. So there's tremendous geographical variability. And then, as I mentioned in the previous slide, a lot of deaths are occurring in hospitals, and there are symptoms similar to COVID-19 in the patients, but it's not clear whether they had COVID-19 or some other respiratory illness that was the cause of death. So in many hospitals, as many as 30% of the deaths that have been documented as COVID-19 are actually in the absence of a test and just based on assumptions based on epidemiological data. Also, the testing, since this is, after all, a new strain of the virus, the tests are not very reliable, and you see that with both the PCR type of testing and the antibody testing, that there's extensive amounts of false positive and false negative results from the patients when they are tested on proven patients of having it or not having it. And then you see as much as 50% error rates. And then also, there are quite a few people who never come to the hospital who may have caught this COVID-19 and they recovered at home and there's no medical data for them. Also, if someone died at home and didn't get medical attention, they're often not counted in the medical records. So the bottom line is that there is no credible data to empirically calculate the clinical or biological fatality rate from COVID-19. And this is a source of tremendous frustration for the researchers because they can't quite put their finger on what is happening in a particular region or a particular country, and it's all very much a guessing game. So we look at some of the comparisons of some of the models that have been developed. I developed a model for calculating the biological fatality rate in the US, and I based that on some of the data we were getting in New York State in the initial stages in March. And I found that the clinical fatality rate at the time was around 2.5%, but for every one patient that was admitted in the hospital, 4 others were asked to go home without any testing done and asked to recover at home because their symptoms were not so severe. So I took the 2.5% clinical fatality rate, divided it by 5 to come up with a biological fatality rate of 0.5%, because the 4 out of 5 were not included in the stats for the total number of people infected. So the clinical fatality rate was artificially high because of the lack of total coverage of the number of infected people in the denominator of that ratio. And then I also estimated that on average, it takes about 18 days between the time a person gets infected and the time of their death if they were to die from COVID-19. And if you look at the Lancet report that came out in April of 2020, they calculated, after all the corrections, the fatality rate of 0.6%. So it was very close to the 0.5% I had estimated a week or two before. And also the CDC has now recently released data that says that the biological fatality rate may be closer to 0.6%, validating what the Lancet report and my model showed months ago. And also there was a Lancet report on some patients in Wuhan in China that suggested that if a person were to die from COVID-19, that they would die somewhere between 15 and 22 days from the day they were infected. So the 18 as an average of 15 to 22 was a good average. Stanford University in early April also developed a model based on the patients that they gathered from Santa Clara County here in California, USA. There were 3,350 blood samples collected, and the people were brought in through Facebook. And also they found that 1.5% of the people tested positive for COVID-19. They corrected for the fact that these people were of certain ethnicities, and there was a gender bias towards females. And so after all those corrections, they said somewhere between 2.49 to 4.16% of the population in Santa Clara had been infected by early April. And if you take the population of the county at 1.93 million, we're talking about somewhere between 48,000 to 80,000 people infected by early April. So what that did was it really reduced the biological fatality rate for Santa Clara County based on these measurements and calculations. So the biological fatality rate was somewhere between 0.12% to 0.2%, assuming that 100 people would have died by April 22nd, because it typically takes almost 3 weeks from the time they get infected to when they could potentially die. So based on the Stanford University COVID-19 model of April, if you take the current number of deaths in Santa Clara County at 224, the estimated number of people infected is somewhere between 112,000 and 187,000. And so the 187,000 is a little less than 10% of the Santa Clara County population. And that could be realistic for this county, given that the infection came early and that there are a lot of dense areas of urban population in this county, and the number of people that have been exposed since the county opened up to the third level, where there's outdoor dining and there are people gathering in commercial areas, that could potentially be true. Now we look at the comparison of the various models for the USA, and we find that at the moment we have about 5.7 million people infected with 176,000 deaths. The Lancet model would take that 176,000 deaths and project that 29.3 million people in the US are infected. And that would be a little less than 10% of the population, and that is pretty realistic. The Stanford model, on the other hand, with the 0.12% to 0.2% fatality rate, would estimate somewhere between 88 million and 147 million people currently having the COVID infection or haven't been exposed to it. And that seems a bit on the high end, because the population of the US is about 330 million, and nowhere close to a quarter to half of the US is infected at the time. The empirical evidence is just not there. So the Stanford model is a bit on the high end, and the Lancet model seems to be reasonable based on the empirical evidence of disease spread in certain US communities. Now I'm going to take you through some models that were developed for India and then compare them with the Lancet and Stanford models to see how the various models are faring after 4 or 5 months of disease spread. So we'll start with the Indian Council for Medical Research, ICMR, and it predicted that somewhere between 1 and 10% of the population could get infected in India by the time the peak hits. And this is called an SEIR model, where S is the susceptibility to the disease, E is the people exposed, I is the number of infected, and R is the number of people recovered. So if we take the population of India at 1.34 billion and estimate 1 to 10%, that is somewhere between 13.4 million and 134 million people infected by the peak in India. And if we say we're getting close to the peak, we can now compare it with the models for Lancet and Stanford and see that currently there are 3 million people infected clinically based on medical records and 57,000 deaths based on the current hospital stats. So if you look at 3 million infected compared to 13.4 million and 134 million, it still hasn't hit that range that the ICMR predicts. However, if we take the biological rate of the biological fatality rate of 0.6% for Lancet, then it estimates that for 57,000 deaths, we're looking at 9.5 million people infected, which is getting close to the low end of the ICMR range. And also the Stanford model estimates somewhere between 28.5 and 47.5 million people infected based on the 57,000 deaths and the biological fatality rate of 0.12% to 0.2%. And so that is well within the range that the ICMR is predicting. If we take the Michigan model, that is a susceptibility infection recovery model, and it's saying that in the absence of any intervention, India could have 16 cases out of 10,000 people at the peak. And if you take the 1.34 billion, this translates to 2.14 million people could be infected at the peak based on the Michigan model. And so the 3 million infected today has already exceeded that number. And if we take the 57,000 deaths and apply it on the Lancet model and the Stanford model, you see that 9.5 million means that we've already crossed that in the Lancet model. And in the Stanford model, also, we are well above what the prediction of the Michigan model was. So what we're finding is that the actual infections that are documented, as well as the 2 US models, would suggest that we've gone way past the estimate of the Michigan model. Recall that the Michigan model was developed back in the April-May timeframe, and they had absolutely no idea of how this thing was going to spread and how quickly it was going to spread over the summer months. Next model is the Johns Hopkins model, and this is India's SIM model with epidemiological modeling, with agent-based modeling, and it includes demographic considerations to develop COVID-19 forecasts for different parts of India. So there's tremendous sensitivity in this model to the different provinces, and it also has the idea of different age groups and looks at the demographic distribution in the different provinces to predict the amount of infection and amount of deaths. So in this model, they've determined that somewhere between 10 and 25 million people could get infected sometime between March and August. And we see that we haven't gotten close to that in the documented infections. There are only 3 million up to now. And based on the 57,000 deaths, the Lancet model is showing 9.5 million. So that's getting close to the low end of the Johns Hopkins prediction. And the Stanford model says somewhere between 28.5 million and 47.5 million. So we're slightly higher than the range predicted by the Johns Hopkins model. The next model is the Cambridge University model. And this is also a susceptibility infection recovery model. And it compartmentalizes people into the 3 groups based on age brackets and the different rates of infection based on lifestyle. So if they're living in large communal housing, then it would spread more. And if they're more in detached homes, then it would spread less. And where they spend time, their leisure. So this Cambridge University model says that if there were a 48-day shelter-in-place program, that the virus would stop spreading. And this assumes that by 48 days, the virus is pretty much not viable anymore in most patients. And so if they remained in place and they didn't spread it to each other, and even if they spread it within their household, people would recover within 48 days, and then there would be no way for them to spread it to anyone else. So based on this model, they predicted that 2,727 people could potentially die from COVID-19 if the shelter-in-place was limited to 21 days. But it assumed that if it went for the full 48 days, that only a handful of people would die. But that wasn't the case. We had 70 days of lockdown in India after many extensions, starting out with the 3 weeks, and then they had 2 or 3 other extensions until they were shut down for a good 10 weeks. And even despite that lockdown for that long a period of time, 3 million people were infected, 57,000 deaths. So the number of deaths that have already occurred are 19 times more, even after there was 49 more days of lockdown than the 21 days that was based in the model. So that shows clearly that there are a lot of flaws in the assumptions made in these models of how people get infected. The clinical results tell a truth that cannot be denied. And so that is why it is important to constantly review the assumptions of models and see if there's something we can do to improve on the assumptions. So the concluding remarks that I have is, one is that these predictive models are not very reliable. The problem that we're having is that there's so many variables, and each model makes a certain set of assumptions that there's tremendous variability in what those models conclude. Also, there is great limitation in both the extent of the testing as well as in the accuracy of the testing. And so the empirical data on infection rates is not very reliable. And also the lockdowns, when we see Spain and France and UK and Germany, the lockdowns, and also China and South Korea, the lockdowns were very effective. But then when we see countries like the United States or Brazil or India, we find that the lockdowns are not very successful. And that despite the number of days, there's so much leakage that people get infected when they're outside, they come home and they spread the virus to their families. Then some family member with the infection goes out and the same thing happens again. So the extent of the disease in terms of time duration just keeps getting longer and longer because there just isn't the absolute seal of the viruses. And then we find also that the clinical fatality rates, for the various reasons I mentioned earlier in the presentation, vary a lot across the globe. And naturally, the biological fatality rate that we see from the Stanford model, as well as the Lancet model, my model, as well as certain countries where there was very, very detailed testing, is that the biological fatality rate is a lot lower than the 6 to 10% that is the clinical fatality rate. And also in the last, I'd say 1 to 2 months, we're seeing a resurgence in the infections in many countries that had lockdowns set up for the months of March, April, and May. So that shows that it doesn't take very much for this virus to come back and start spreading again in the absence of a vaccine and in the absence of sufficient social distancing. So in conclusion, I would like to thank Dr. Shahid Jamil, who I co-authored a paper with that is the basis of this presentation. And I'd like to thank Observer Research Foundation in India that published our paper. And there is a link here on the slide for finding that paper. And I would also like to thank the organization Merck, KGaA, for inviting me to speak at this conference. My contact information is provided here with both email and phone number. And I look forward to your comments after you've seen this presentation and answer any questions that you may have. Thank you and have a safe and wonderful fall season. Thank you.
Thank you, Dr. Ibrahim, for a great presentation. That was the final presentation of Theme 2. Now, please join us for a live Q&A with all the speakers.